Health for Life. This is the first ever medical show on television that deals with prevalent health problems and concerns, and they do so in an easy to listen to question and answer format. To find out what we're discussing today and to introduce us to the visiting specialists, here is the producer and the host of Health for Life, Dr. Surendra Prasad.
You talked about arthroscopy, and the literature continues to talk about the pluses and minuses of arthroscopy. Maybe you can comment a little bit about the role of arthroscopy in joint diseases.
Well, arthroscopy in degenerative joint disease, at one time in its evolution, was a big thing. Most people with degenerative joint disease would get an arthroscopic shaving of the knee. Now it's falling into disuse because we recognize that arthroscopic shaving does not resolve the degenerate problems of a knee. And I said earlier, the indication for the arthroscopic shaving of the knee is when the patient has manifestations that there's a meniscal degeneration that is causing meniscal locking in the joint, and we need to get that out of the joint. So that's really the indication for arthroscopic shaving in an osteoarthritic or degenerate knee.
Now, in terms of joint replacement, you have been involved in joint replacement of knees and hips in Guyana since we've been doing them. Mm-hmm. Can you comment a bit about where you started, where we've come, and where you want us to be going or hope to go in the near future?
Well, joint replacement surgery in Guyana started in 2001. Prior to 2001, I do not think, I stand corrected, but I do not think that any total joint replacements were done in Guyana prior to 2001. I know that partial joint replacements were being done for a long time, and in the presence of Project Dawn, I know they did quite a lot of work, but I cannot remember seeing recorded any joints prior, total joints prior to that. Now, we started off in Guyana with the help of the National Insurance, who actually were able to acquire the joints, and we started doing joints through the National Insurance since then. And we have had patients having these joints done, but these joints were a lower cost joint that sometimes the quality of the joint sometimes is a little questionable, but I have patients with those joints that have gone for more than 10 years. Because if we start in 2001 and we're now 2014, so we have those patients. Now we are at a stage where we've gotten much better joint quality, both hips and knees, and patients are benefiting from these joints both in the government as well as in the private institutions. The biggest problem we have about joints is not putting in the primary joints, is that we're coming to a stage where we have to start doing joint revisions. And I remember there was an Italian group of doctors who came, I think in 2003, and they did quite a few joints at the Georgetown Hospital. But basically they did hips. And I'm now seeing those hips returning for revisions. So we have to now improve our technology because it's no longer primary joints. It's joint revision now. And joint revision is even more expensive, even more technical. So we have to go. I've already done training programs for revision joints, but we need equipment. And if we can get the equipment, we should be able to do revision joints in Guyana. So that's where we're trying to head, to be able to do revision of the total joints that we would have done 10 years ago.
As you will recall, Dr. Jeffrey is here with us in the studio, and the topic we are discussing today is degenerative joint disease. We are specifically now going to be discussing knees and hips. And so, Dr. Jeffrey, let's talk a little bit more in detail about how the total knee replacement is done. What's the general age group? Is it a general anesthetic, positioning, procedure, recovery time? Let's start with the knee, total knee replacement.
Okay, well, first and most important is the patient needs to understand that a total knee replacement is a major surgery.
Okay.
So you have to be properly prepared for this intervention, meaning you need to be healthy, you need to have medical checkup that will actually authorize the surgeon to be able to do your surgery safely.
Okay.
And if you have an underlying condition, it doesn't mean it excludes you from having a total knee replacement. You just need to get the underlying condition under control, like diabetes, for example, or hypertension. And once those are controlled, then we can proceed with your procedure. So it's now a contraindication for a total joint if you have these underlying conditions.
So generally the patient will get an evaluation by a medical doctor or an internist to ensure that they are physically fit, medically fit for the surgery.
Yes.
Now, what about the type of anesthesia that is used?
Now, the type of anesthesia is most times dependent on the patient.
Okay.
The patient has a choice. The patient can choose either doing general anesthesia, or the patient can choose to do spinal anesthesia, which is known as regional anesthesia. Okay. Now, the difference between the two anesthesias is that the general anesthesia patient goes to sleep and usually will have to be awakened by the anesthesiologist, and the tendency is that the side effects of anesthesia sometimes make them a little drowsy and they are unable to do the things that the person who had a spinal anesthesia would be able to do, like eat almost immediately after surgery and chat with the surgeon all the way through. So those are the differences. But other than that, there's no real major difference. And in some places which we are not doing as yet, the spinal anesthesia sometimes gives us the advantage that we can also leave an indwelling epidural catheter so that the patient can actually medicate themselves for pain relief.
Now, in terms of the duration, what's the average length of time for this surgery, the total knee replacement?
Well, there is always a learning curve.
Okay.
And in the initial, when a surgeon just begins doing a knee replacement, the average time he will take is about 2 hours, sometimes 2.5 hours. But as the learning curve changes, you find that now we take about 1 hour 15, 1 hour 20, sometimes an hour and a half, and this is dependent on the state of the knee.
Okay.
It's unfortunate, that patients in Guyana usually come to us very late.
Yes.
They wait until the very last moment when the knee is completely degenerate and there is basically no more hope for the knee. But that's sometimes not the best time to do it because it makes the surgery a little more difficult for the surgeon.
Now, and the average length of time that person is going to be in the hospital after the surgery?
Well, the surgical intervention takes about an hour and a half. The patient comes in the day prior, so he or she could be adequately prepared for surgery. And the patient has a drain left in the knee, which is the real determining factor of how long the patient stays in the institution. The tendency is that on the second or third post-op day, once there is drainage that is acceptable, usually about 50 cc's or less drainage coming from the knee, we remove the drain and the patient is allowed to go home.
Okay. So a general or a regional anesthetic, about an hour, hour and a half, 2 to 3 days in the hospital maybe.
Yes.
And how about the limb itself? After you've done the knee, do you restrict them from moving it, or you encourage them to move the knee? What's usual?
Well, as soon as surgery is done and the patient has recovered from their general or spinal anesthesia, we visit them on the ward and we get them in their immediate exercise regime. So the patient is started by doing leg pump and other different exercises for the legs, simple exercises. And basically the whole idea with this is to try to reduce the incidence of deep venous thrombosis after the surgery. The patient usually gets up and walks the next morning. There are some places, or sometimes I get patients who would be willing to get up the same night if they had their surgery earlier. So we let them get up on the night of surgery and they start walking. So there's really no time in bed. you get up and you start walking almost immediately.
Yeah, and I think that must come as a surprise to a number of the patients that you can have that surgery and we really want you to get going.
Yes, most patients, when they first come to consult about the surgery, they ask you, Doc, how much time will I be out of action? How much time will I be in bed? And when I say no time at all, then they're really surprised that you can actually get up and walk the next day.
And from what I've read, I need you to tell me if this is true or not. From what I've read, most patients who have had their knee replacements, one of the things they commonly say is, I wish I had done it earlier.
Yes, because what happened, the fear of the surgery is one of the reasons why patients take a very long time to come and decide that they're going to do the surgery.
Okay.
And I've had patients who had this fear and did one side first, and when they find out that on occasions we can do both sides, they come to you and they say, Doc, why didn't you do both at one time? Because the one that is not done is now creating so much of problems, I really need to get it fixed. But doing both sides is a decision that we need to make dependent on the state of health of the patient, the age of the patient. There's no age limitation for doing the surgery. Some people think that I'm too old. No, there's not an age limitation, but the surgeon and the anesthesiologist need to decide which patient would be able to tolerate doing both knees at the same time, or we should stage it and do one and then probably come back in a couple months and do the other side.